1 minute, but I'll restart. Good morning and welcome to another monthly coaching call for the HIV Continuum of Care Collaborative. My name is Christina Clark. I'm the HIV Continuum of Care Collaborative Project Director and Quality Improvement Coordinator at the BC Centre for Excellence in HIV/AIDS. I'm very happy to be facilitating this 5th coaching call in a series of 12 monthly coaching calls that will occur from now until January 2015. The purpose of these calls is to provide collaborative participants with a space to share good ideas, find support through challenges, and connect with others to further our shared aims. First and foremost, these calls are meant to be relevant and useful, so we hope that you'll speak up to share your own ideas, challenges, and questions. In today's call, we'll summarize and highlight conversations and key concepts from Learning Session 2. We'll spend some time clarifying the activities and expectations for Action Period 2, and then we'll have time for discussion. So we'd love at this point to hear from what you learned, how you plan to spread what was learned with other team members, your plans for Action Period 2, and any connections you made at the learning session. As always, please feel free to use the chat box throughout the conversation today, and we'll try and facilitate that box as well. So let's get started. I wanted to kick off. Let me just get my slides up and ready. So I wanted to get everyone involved early, and I've got a few simple questions to kick us off. And so what I'd like everyone to do is to locate the hand raise button, and if you attended Learning Session 2, I just want you to click on that hand raise button. So it looks like we have looks like there's representation from everyone on the call right now who is at the Learning Session 2. So that's great. For everyone that was at Learning Session 2, this content should be a little familiar. We're going to provide a high-level overview of the key topics and content from the learning session. We'll also touch on Action Period 2. As feedback indicated, this could use a little more clarification. As you listen, think about your own personal reflections from Learning Session 2. How have you or will you apply these key concepts? How will you get the most out of Action Period 2? How will you disseminate what you learned to other members on your team? So think about those questions and feel free to add your reflections into the chat box throughout. So the next really simple question is there anyone on the call in your settings that did not attend Learning Session 2? And if so, please again click on the hand raise button. All right, looks like Janice, you're in Port Alberni. You weren't at Learning Session 2, and maybe a few members from your team weren't also. So for everyone that wasn't at Learning Session 2, it's pretty customary for team representatives to attend the learning session and a few members to stay back. So as you listen today, much of this content may be new to you, so you're encouraged to ask questions throughout. As you listen, think about how you might be able to apply these concepts and check out all of the material and presentations from the sessions that have been uploaded to the website, and all of the videos again will be uploaded to the website at the end of next week. So before we have a brief review of some of the highlights from Learning Session 2, I thought we could move on to a few more challenging questions to warm us up. And while those that attended will certainly have an advantage here, this should be relevant and pretty fun for those that were not at the learning session as well. So please go ahead and take a shot at the questions as we move forward. So here's the instructions. A question will appear on the slide. After I read the question out loud, type your response into the chat box. So it's going to be a multiple choice question. So if you select A, put A into the chat box. If you select B, put B into the chat box, and so forth. So I'll read the question out loud for everyone. It's also on the screen, but for those who are only connected to phone, perhaps, I'll read it out loud. Question 1. In this morning presentation at Learning Session 2, Dr. Rolando Barrios presented provincial data from the most recent quarterly monitoring report. So this would be the first quarter of 2014. So the first question is, in this first quarter of 2014, what age group of British Columbians had the lowest number of HIV test episodes? Test episodes being the number of HIV tests ordered. So do you think it's A, under 30, B, 30 to 39 years old, C, 40 to 49, or D, 50 years and over? So I'll just give a few moments for people to think about that. Again, just type your lettered response into the chat box. Looks like we have 2 A's so far, so that's under 30 years old. And we have 1 D, 50 years and older, and another D. So 2 A's and 2 D's. So the answer to this question is actually 40 to 49 years old. So the lowest number of HIV test episodes was among those in the 40 to 49 year age group. The highest was found in under 30, followed by those in the 30 to 39 age group, again followed by those in 50 years and over, and finally those aged 40 to 49. So kind of interesting and not altogether intuitive. So that's again included in the quarterly monitoring report, which you can find online for review. And it's sliced down for each of the health authorities as well, so you can get a sense of what's going on in your own health authority. All right, so let's move on to question 2. What proportion of HIV positive British Columbians that are diagnosed are on treatment as of the first quarter of 2014? Do you think it's A, 62%, B, 71%, C, 79%, or D, 91%? So we have a B, a C, a B, another B, and another B. Great. It is in fact B. Well done. So the answer is 71%, and this was presented from the Cascade of Care for BC. You can find this information in Dr. Barrios' presentation, which is available on the website. And of course, it's drawn from the quarterly monitoring report in the Cascade of Care at the same location. Well done. Next question, question 3. How many British Columbians with an HIV diagnosis are not achieving viral suppression? Do you think it's A, 1,720, B, 2,452, C, 4,001, or D, 4,369? So again, how many British Columbians with an HIV diagnosis are not achieving viral suppression? I think we have 1 A so far. Another A. Another A. And another A. Do we have a little bit of groupthink? Is anyone going to hazard another guess? We have 1 B. And another B. Okay, great. Thanks for your responses. So, how many British Columbians with an HIV diagnosis are not achieving viral suppression? The answer is actually 4,369 people. So there's about 9,395 HIV diagnosed individuals living in BC, and among those, 5,024 are achieving suppression. So what that means is that almost half of all British Columbians with an HIV diagnosis are not achieving suppression. And this is one of the pressing gaps that we are here to focus on. So I see Janice has put in a, All right, on to the next question. True or false? The rate of viral suppression among youth, so those 30 years and less, is better than those observed among women and injection drug users. Do you think it's A, true, or B, false? So the question is, True or false, the rate of viral suppression among youth 30 years and less is better than those observed among women and injection drug users. True, A, or B, false? We have 2 A's and 2 B's. So it looks like an even split. All right, and the correct response is B, false. So youth have actually some of the worst suppression rates when compared to other groups diagnosed with HIV. And this is a slide from Dr. Barris's presentation showing suppression for youth at 33%. That means 2/3 of youth are not achieving suppression, which is quite surprising. Some other gaps are highlighted for women who are achieving suppression rates of 44% and injection drug users at 56%. So again, these are some of the gaps we're looking to close. So thanks for your response to those ones. We have just a few more questions. True or false? There is a higher burden of HIV among First Nations people. Do you think the response is A, true, or B, false? We have A, and another A. Looks like the consensus is definitely true, and that is correct. So the answer is in fact true. Dr. Shannon Waters presented on engaging First Nations people in the HIV continuum of care and described firstly the need for better data, but also that there's a higher burden of HIV among First Nations people. And this is another area of focus for us to be thinking about. Next question. Question 6. This one might be a little challenging. What team presented this aim statement at the learning session? So the aim is ensure all clients are afforded the best HIV testing and prevention services when accessing blank clinics by routinely offering HIV testing to 95% of all clients. So do you think it was A, Quick Links, B, BC-CdC, C, the Nanaimo team, or D, Pender Clinic? So we have one B, another B, again another B, and one response for A. Yeah, the Quick Links, and one more for C, for Nanaimo. All right, great. So the correct response is BC-CdC, and just to let you know, we're currently synthesizing all of the team's presentations from the learning session, so you'll be able to review them online. We're going to have both the video presentations uploaded by the end of next week, but at this time we have on the website all of the actual presentations delivered, the slides that is. Question 7. The Fraser Health STI BBI team shared their aim to work with 3 family physicians to collectively achieve 95% engagement in care. So how have they defined engagement in care? A, 2 visits at least 60 days apart in the past 12 months. B, 2 visits in the past 12 months. Or C, at least 1 visit in the previous 4 months. Or D, 1 plasma viral load test in the past 6 months. So, responses A through D. Looks like we have one A, another A, lots of A's. Great, looks like you guys are paying attention. It was in fact A. So that's the standard engagement measure for engagement in care. And again, just coming back to this is the front page of the StopHIVAIDS.ca website, so you can click on that main slider and you can look through all of the team presentations. They're uploaded in a PDF file. Question 8 is our last question. True or false? Action period 2 is the time between learning session 2 and learning session 3. Do you think it's A, true, or B, false? A. 1B, another B, another B. All right. So action period 2 is the time between learning session 2 and learning session 3. That is true. And this marks the last question and hopefully helped you to identify some of the key resources that are available on the website. It's really the best source of information at any given time, and you can check out all of the slides. The recorded presentations, again, should be there by the end of the week, of next week, I should say. And so let's move on. So Clemens was going to be with us to give us a brief overview of the key concepts from the learning session, but I don't see his name up there just yet. So I think what I'll do is I'll begin, and hopefully he'll be able to join us a little bit later. So for those of you that were at learning session 2, this is probably going to be a bit of review for you. But I think what this is helpful for is for those team members of yours who weren't at learning session 2, this provides a source of reflection and an opportunity for them to engage with some of the material and to be able to source out all of the material that was created at the learning session. So I'm just going to start by reviewing the agenda from learning session 2 and some of the key concepts. So what we began with at learning session 2 was an opening prayer by Elder Leonard George. And Leonard, his presentation will be uploaded to the website, and he shared with us some words for engaging not only First Nations, but also for thinking about stigma and thinking about some of the barriers that people face that have HIV and how we can make that better and increase engagement and care. We also had each team provide a bit of a team introduction. Who are they? What is their team mascot, and what does that represent to them? Dr. Rolando Barrios provided a review of our collective progress and discussed some of the current gaps in testing and HIV outcomes, and specifically emphasized some of the gaps in care for youth, for women, for Aboriginal persons, and for injection drug users. So he pointed to, this is why we're here, these are the gaps that we're trying to close. We then had a Four Corners mentorship and networking activity where lots of people were up and about. This was pretty fun, pretty loud. People were getting to know each other, hopefully meeting people for the first time. And the importance about this activity was that you could meet people that you would hopefully develop strong networks and relationships with to both further your mutual aims. We then had storyboard presentation. Each team shared their progress in working towards their aims. Some teams shared their aims, their data, some of the progress they've achieved over time, some of the challenges they're encountering. And again, all of those team presentations are uploaded to the website, so I encourage you to take a look at those. In the afternoon session, we had Dr. Shannon Waters, who discussed engagement of First Nation groups in BC. She pointed to the diversity of First Nations groups, the need for self-determination, the disproportionate burden of HIV among First Nations people, and the importance of becoming culturally competent through training, and also about creating culturally safe places to increase engagement and care and outcomes for individuals living with HIV. We then moved into some breakout sessions in the afternoon where everyone self-selected topics to talk about. We'll have all of the transcripts from those sessions uploaded today. It's a little bit difficult to interpret perhaps if you weren't at that session, but you might want to follow up with the facilitators for each session if there was some key concepts that you might be able to learn about. We had team action planning in the afternoon where Dr. Kathy Rhines led us to basically use that time as needed, create some next steps and tangible ideas for changes going forward, and to create a project management framework around that. We then had offers and requests, and those will be on the website today as well so that you can match up with teams that had their offers and follow up on some of your requests to other teams about how you can help. And feel free to use the listserv to spread some of the tools that you have available. And then we provided a wrap-up and evaluations, aha moments, and I'll provide a little bit more in-depth about the action period going forward. So in summary, some of the key concepts from the session were using data to identify and characterize improvement targets, including the provincial level data, your own improvement data, the quarterly monitoring reports. The importance of working together, developing strong networks, crossing boundaries. The importance of looking outside your own population, beyond your own walls for others that are in need in your community. And of course, staying focused on your own goals, gathering ideas for improvement, testing, documenting your changes, and leading towards improvement. So I'm going to have a brief pause right now and see if there's any questions about Learning Session 2 or anything you wanted to follow up on. So go ahead and use the chat box if you have any questions. You can also unmute your phone line if you'd like to ask a question using *6. Or you can raise your hand if you're on the webinar and we can unmute your computer. All right, hearing no questions just yet, we'll push forward. But again, feel free to use the chat box throughout. Action period 2. I just want to really briefly go over action period 2 because I sense that there may have been a bit of lack of clarity based on some of the feedback about what goes on and what can be expected during the action periods. So an action period is the time between learning sessions when teams work on improvement in their own home organizations. They're supported by collaborative staff and faculty, and they're connected to members of other collaborative teams. Action period 2 runs from May 19th, so just after the second learning session, to September 24th, the third learning session. And that's actually the final learning session before the closing Congress in January, where we think more about harvesting some of the ideas and celebrating some of the success and changes. So during these 4 months, June, July, August, and September, teams should make sure that their aims and measures are in place and they're really providing the foundation to the improvement work. Action period 2 is the time when teams will really start focusing their attention specifically on testing changes and observing the effects of these changes on helping them to reach their aims. If we think back to the model for improvement, you will have clearly defined your aims. So that's what are we trying to accomplish? Your family of measures, how will we know that a change is an improvement? And we'll be actively looking for changes to lead to improvement. So you can look to the change package, which is on the website. Those are changes organized by each of the aim foci in the collaborative. And then when you have this list of changes that you may get from the change package, from learning sessions, from brainstorming sessions with your own teams, you take it into the action component, which is the PDSA cycle. And this is where your team would take your changes and begin to test them on a small scale. So just a quick review of the PDSA cycle. It is a method to test a change before implementing it. So PDSA cycles are things you do every day without really thinking about them. There's 4 steps in the PDSA cycle. First, you would want to plan your change. So think about what's your objective with the cycle, what questions and predictions do you have, and what is the plan to carry it out? So who's going to do it, what are you going to do, when and where, and then a plan for how you're going to collect some observations. You then want to do your test of change, so you're carrying out your plan. So you're carrying out the who, what, when, and where. You want to document any problems or unexpected observations as you go through and begin your analysis of some of the artifacts that you're collecting to analyze your test of change. The next step for 2 steps of the PDSA cycle are to study what happened by gathering your observations and by analyzing them. So compare your data to predictions, summarize what you learned. And then the last step is to act. So what changes need to be made? Do you need to adapt the change? So maybe you want to tweak it a little bit. Do you want to adopt it completely? So it worked perfectly just as you predicted and now you're ready to implement it. Or did it not work at all as you had envisioned and you want to abandon it? What are your plans for your next cycle? So how will you scale that change up? If you're thinking about why you might want to test, why you would want to use the PDSA cycle, here's a few reasons. So you might want to break down a change and make it a little bit more manageable. Often changes need to be adapted to your own context and to your own needs. Your situation is not the same as somewhere else where that same change may have worked really well. You want to build belief that it will work. So what's the degree of belief you have in this change? Testing it can provide a mechanism for you to see that change in action, to build belief that it will work. Testing also helps you to catch unintended consequences. So these are things you didn't actually foresee when you first envisioned your test of change. Testing is also really great to gather other people on your team, in your clinic, to build ownership for the changes. So when people have a part in making that change a reality for the clinic or the program, it's more likely that they'll build ownership in the changes and it'll be a better change when they are involved. And sometimes you just want to test a change to end a long and boring meeting. So sometimes you can suffer from analysis paralysis where you can discuss at length the merits of a change and some of the risks of the change, but sometimes you just got to say, let's just try it, right? And so testing a change helps you try it. So during action period 2, you'll want to work on testing changes out using PDSA cycles. You can slowly introduce changes into your practice using this iterative learning process. Over time, as you test changes, you'll develop a better sense of the likelihood that the change will lead to an improvement. As you do this, you will also begin to scale up the size of the test of change from a very small scale test. So for example, trying out a new survey with one patient on one day, to follow-up tests. So you would tweak the survey based on tester information and then try the new survey with maybe a sample of 10 patients in 1 week. To a wide-scale test of change, so maybe you're testing with all clients at the clinic over 2 weeks. Through to implementation, so now you've developed processes, you've articulated the processes for the survey, you have policies and instructions in place, the surveys are regularly and routinely and standardized in their delivery. Data collector and analysts are trained in how to synthesize and interpret the data. So that's the difference between a small-scale test and implementation. And you can see that there's a difference in how much resource would go into something like implementation, where it's very resource heavy, from the very small scale where it's limited in its resource. So when you think about scaling up your change, this table can be helpful. So think about 3 things. Starting from the left, what is your degree of belief that the change will lead to an improvement? Do you have low degree of belief that the change will lead to an improvement? Or maybe you have a high degree of belief. Next, think about what is the cost of failure? Is it going to be a pretty high cost, or is it going to be pretty low impact to your clinic or program? And then when you move from left to right across the table, look up at what is the level of commitment to the change from the staff. So if you have no commitment, you're really going to want to try it on a small scale. If you have stronger commitment, you can move further along the rows. So as you begin to think about these 3 elements, it can really guide you to select a scale of tests that will help you progress. So for example, if you have a very high degree of belief that the change will lead to an improvement, the cost of failure is small, and there's a high degree of staff commitment, then you would simply implement the change. But of course, you wouldn't usually arrive at implementation at this after testing something several times. You'd want to build certainty and commitment and make sure you expose and mitigate any risks that might be associated with the change. In action period 2, as you keep testing, there's a few key dates to support you along reporting to keep up the pace of change and to help us provide you with guidance and coaching, monthly teleconferences to bring ideas and connections, and the next learning session again is held in September. So again, at this point, I'd like to come back to some time for questions. If there's any questions related to the content, go ahead, raise your hand if you'd like to be unmuted. You can also type your question into the chat box. And then if there's no questions about the content, we have some more specific directed questions to move into. All right, hearing no questions about the content itself, I'm going to bring up a question. For those that were at the session, I'm interested in hearing from you about what was valuable about learning session 2 and why. And from those who weren't at learning session 2, I'd like also to hear from you after having an opportunity to perhaps reflect on some of the key concepts that I just went over. What do you think was valuable about some of those key concepts, and how do they change what you're thinking about right now? So again, looking for responses to what was valuable about learning session 2 and why, I'm going to ask everyone to either chat it into the chat box. You can also raise your hand so we can unmute you. You can press *6 on your phone to be unmuted as well.
Hi, Christine. It's Denise here.
I can hear someone speaking, but you might need to move a little bit closer to your microphone.
Hi, it's Denise Thomas from First Nations Health Authority.
Hi, Denise, go ahead.
I thought it was really valuable to meet everybody face-to-face, build those relationships, and get to know everybody in one room. I thought that was really valuable.
Thanks, Denise. I'm sorry, I'm having difficulty hearing you. I think it's because we're having a fan issue in our room. We can't figure out how to turn off our fan. I did hear you say, though, that it was really valuable to see people face to face, and I couldn't agree more with that. Just the energy in the room when I compare it to some of the video conference learning sessions was tangible, and the ability to connect with people and to trade information and make new connections, sometimes for the first time, I could really see that happening. So I thought that was a success for sure. So I have one comment from Janice in the chat box. Tanya, a member of the Port Alberni team, says the most evident thing for me was that the external programs had such little connection and understanding of the on-reserve programs. Janice, I'm wondering if you or Tanya might be able to explain that a little bit further about what you're thinking. Are you able to unmute yourself?
Hello?
Hello, go ahead.
Hi, it's Tanya. It was pretty profound for me when I talked to a lot of the external programs or off-reserve programs throughout BC that it was a bit of an eye-opener about when the First Nations clients are kind of accumulating in places like the downtown east side or outside of the reserves and reasons why they're leaving. And it was just, we had a lot of discussion around how the most important thing for us was to be home and how difficult it was from the stigma and experiences they had around their positive diagnosis to maintain and stay at home. So it made people look at things differently when they're providing or when they're thinking about providing care to people off reserve and the importance of having that cultural competency.
Mm-hmm. So Tana, is there something you took away about something that you can do differently or perhaps connections that you can make?
I think it really brought I came as a solo from Port Alberni and then kind of tagged in with NTC and the First Nations Health Authority. And for me personally, it really indicated that we have to work from the higher levels, maybe through First Nations Health Authority and their infrastructure we have to disseminate that information and try and create those connections and build those bridges to be able to work together with this, because the majority of our people are off reserve, and if we're only providing services on reserve, then we have to figure out how we can communicate minimally and try and provide some support for those off reserve providing services to our HIV positive clients. We have some work to do on both sides of the bridge, really.
Great, thanks, Tanya. Did anyone else have a similar experience? Perhaps if there was no similar experiences to that, how does anyone on the call think about how they connect with or have a greater understanding of some of the programs that are available on reserve and connection points for that? Again, feel free to use the chat box or raise your hand and we can unmute you. If you're only connected by phone, you can press *6 to unmute yourself. So perhaps that question will be a work in progress and something for teams to think about moving forward. So I'm going to move on to one of our next questions. Did you hear an idea at Learning Session 2 that you would like to try out? What was one idea that you heard at the learning session that you think you'll be trying out? And I see a comment from the trio, Tracy, Margaret, and Janet at Central Ontario Native Health, I think they are coming from. I think providers from the Northern Reserves need to be connected to this collaborative. And looks like they're typing a little bit more. So I'll hopefully ask one of you guys to speak a little bit more about what you're thinking about how we could increase that connection to the collaborative. And while you are thinking about that, Everyone else, what do you think? Did you hear an idea at learning session 2 that you would like to try out? Don't be shy, guys. There must have been one idea you heard at learning session 2 that you might want to try. So a little bit more from Tracy, Margaret, and Janet. These are two primary care providers that have many First Nation villages in their care and have established relationships with the community members. And Denise is asking, are you able to invite them as members of your teams perhaps, so increasing that level of connection? Okay, and they would be better as their own team. So I'm wondering, from the trio, if we could have you unmute yourself and maybe you could tell us a little bit more about what you're thinking. So no mic on the computer. Okay, no problem. And sad face. So it could be that maybe Denise and Tracy, Margaret, and Janet might want to connect a little bit later and follow up on this idea. What about others? Did you hear an idea at learning session 2 that you would like to try out? So maybe while you're thinking about it again, go ahead and use the chat or unmute yourself. I sat, during the team action planning time, I sat with some members from the DCHC, Downtown Community team, and the MAT, the Maximally Assisted Therapy team. And what they were looking at doing is they had heard ideas earlier in the session from Dr. Shannon Waters. And what they wanted to do specifically was to increase engagement for their First Nation clients. And so some of the ideas that they heard were around the cultural competency training. And so they're going to aim to have all of their client or their clinic members, so their staff members, taking that training by a certain date. They also want to increase the cultural safety of their clinic. So they're looking at how they might do, not necessarily renovations, but how they might do simple things to increase the cultural safety of their clinic. So adding signage in local languages for First Nations people as an example of one of the changes that they're going to try out. So those are just a few examples of changes that I heard a team here at the learning session. So what are some of the ideas that you heard that you would like to try out? So maybe learning session 2 is a little more faded in your memories, but there are lots of resources online, all of the team presentations, all of the presentations from the session. If you want to go back and look for more ideas, they are all available there. Here's another question to put to you. Did you make a connection with someone new that will help you meet your mutual aims? I see Denise says, relevant to the last question, we would like to try out sharing recklessly to decrease stigma and discrimination by sharing resources. I think that's a great idea, Denise. Did anyone else have any ideas that they'd like to try out or any connections that they made after the second learning session? Maybe while we're waiting, Denise, if you're able to unmute yourself, I'd love to hear more about what you're thinking about how sharing recklessly is going to help to decrease stigma and discrimination. Here's a little bit more. We'd also like to assist with connecting healthcare providers working in communities to existing HIV continuum teams. So please email Denise Thomas if you're interested in that connection. A good one, absolutely. So Denise, are you able to unmute yourself to tell us a little bit more about how you're going to share resources? No microphone. Okay, unfortunate again. No worries. Denise put into the chat box, there's a new First Nations Health Authority map that has both community locations and healthcare facility locations that may assist other teams with that important piece of connecting. Denise, do you have a link you might be able to share? So there's a PDF document available to anyone who is interested in that important piece of connection and the First Nations Health Authority map. So go ahead and follow up. I don't think you can send it out through the chat, Denise, but absolutely, if you want to email it to me, or you can send it out to the listserv, might be the best way to do it. And I'll just type in the listserv email address here. So Denise, if you would be able to send out that PDF document to the listserv, that would be really helpful, I think, for other teams. So here's another note from Gail. Hi there, we are here from the Pender Clinic and a wee bit behind in that we do not have our POF identified, so the population of focus identified as of yet. I want to sit with our team and brainstorm how we may get our registry completed, and then somehow canvass the larger clinical team to ascertain who may know individuals in our population of focus and can assist with engagement. That sounds like a great next step, Gail. So one question from someone unidentified, is there staff for Surrey geographic area? I'm not sure what, maybe a little more information would be helpful for that question. So clarification is for First Nation Health Authority staff. Is there staff or contact for the Surrey area? So maybe Denise, you can answer that question. So I just want to come back up to Gail's point about identifying the population of focus. Gail, I'm wondering if you're thinking of using or including in your population of focus all individuals with HIV, or are you thinking more of a subset, for example, your co-infected clients, so maybe Hep C and HIV as your population of focus? So in response to the guest who asked the questions, their staff for the Surrey geographic area from First Nations Health Authority, Denise responded that she'll review and get back to you, and asking if you can connect via phone. So maybe guest, if you're able to include your contact information, or if you'd prefer, Denise has included her email address above.
Christina, can you hear me? It's Shayla.
Yeah, go ahead.
I'm calling from Fraser Health, so just want to let you guys know that there is Klahowya Healing Place, a primary health care clinic that has some Aboriginal health services, and they do connect with us as the HIV Hep C clinic when needed.
And that was called the Healing Place, Shayla?
That's called Klahowya, and I'll send the information on the website.
I'm muted.
Perfect.
Oh, that's great. Thank you, Raymond.
All right, look, if there's no more responses or ideas about things you're going to try or connections you've made, with just a few more minutes left, I'm going to close this up, but please feel free to use the chat box for the remaining couple of minutes. So I just want to thank everyone for coming to this call. I hope that it was helpful for you today to gather and synthesize some of the ideas, locate where the resources have been placed after the learning session. Some key dates for going forward. We just had the last reporting deadline on June 6th. Of course, we're still accepting reports if you're a little behind on them. Just please follow up with myself to let me know about when you anticipate getting that in. and we'll get you some feedback. We have our next teleconference on July 8th as well. That's the next reporting deadline on July 8th. So look forward to reconvening at that time and to seeing some of your reports again in the next month. Until then, I wish you guys a great month of June, and thanks again for joining us today.